Well,
She just said she was on. Okay.
I'll go ahead and get started. Okay, Frida, you can go to the next slide. Well, today we're talking about prebiotics and probiotics, and we'll go ahead and start with the WIC mission. If somebody in Region A wants to read the WIC mission for me.
I got it. The mission of the WIC program is to safeguard the health of low-income women, infants, and children up to age 5 who are at nutritional risk by providing nutritious foods to supplement diets, information on healthy eating, and referrals to health care.
Okay, and if someone from Region B will read the public health mission for me.
I've got it, Lindsay. The public health mission is to inform, prevent, and protect.
Okay, thank you. Slide. Oh, thanks, Frida. All right, so like I said, today we're going to be talking about prebiotics and probiotics, which I think is a really interesting topic, and I don't know about everybody else, but I'm pretty clear on some things about probiotics, but as far as prebiotics go, you know, that's kind of a little bit shady territory. And even though it doesn't seem like something that we might use a lot in our line of work, it is something that we can incorporate into our nutrition counseling. So today the objectives, by the end of the session, you will more fully understand the definition of prebiotics and probiotics, the basic function of the Human Microbiome Project, the basic concept of the gut microbiome, benefits of prebiotics and probiotics, and also implications for use of these prebiotics and probiotics in nutrition and in the WIC program. All right, so first, just to define what probiotics are, of course, the root of this word is Greek, pro meaning for and bio meaning life, so it is meaning for life. And the definition, there have been many, many definitions over the last couple decades, but the WHO and the FAO have decided that the basic definition is live microorganisms that, when administered in adequate amounts, confer a health benefit on the host. Okay, so that's a pretty vague definition, but it really is kind of any microorganism that is beneficial for our nutrition and our life. So a little bit of background behind probiotics. Probiotics in the last decade or so, and prebiotics have kind of been all the rage. You know, they're adding more to yogurts. People are taking probiotic. There's new organisms added to different products. But there's record of probiotic type foods being used as far back as 2,000 years, specifically bacterial drinks. And if y'all have ever looked into like other countries and what they do with their foods, a lot of other countries use fermented foods as a daily part of their diet. So Americans don't use as much as a lot of the other countries do, but that's where a lot of these probiotics are going to come from, is some of these fermented food and drink products. All right, so kind of how it all got started was the advanced work by Metchnikoff in 1907 at the Pasteur Institute in Paris. And I'll talk a little bit more about Louis Pasteur because he kind of is the one who started really all of this research. The different types of probiotics are going to include the lactobacilli, streptococci, enterococci, lactococci, and bifidobacteria. And then also included are going to be some fungi and yeast, such as the Saccharomyces and the Aspergillus. All right, so some of the desirable characteristics of probiotics, because probiotics are microorganisms, you want to kind of define the probiotics from the ones that are not beneficial for human life. So there are desirable characteristics. Number one being there has to be a beneficial effect when consumed. They also have to be non-pathogenic and non-toxic. So in our gut, we have a lot of bacteria, and I'll talk a little bit about that. But we have a lot of good bacteria, and then we also have a lot of bad bacteria. So, these probiotics are going to be the ones that are going to be non-pathogenic and non-toxic. Large number of viable cells. So if you're going to take a probiotic, you're going to want there to be enough cells in there. Colony-forming units is how they're going to measure that. There has to be a capacity to survive and metabolize in the gut. So that kind of goes back to that large number of viable cells. It has to retain its viability during storage. So, you don't want a product that is going to lose the live microorganisms while it's being stored before you can actually use the product. And then if incorporated into food, it really should have a desirable sensory quality. So, you want the product to actually taste good. All right, so now on to prebiotics, which I think maybe is a little less clear to a lot of people what the prebiotics actually are. But the most recent definition that I found from 2004 is selectively fermented ingredients that allow specific changes both in the composition and or the activity in the GI microflora that confer benefits upon the host's well-being and health. So what does that mean? I mean, that's kind of a vague, again, definition, but it really includes any non-digestible material that enters the large intestine can actually be a candidate to be a prebiotic. A lot of these are going to be the polysaccharide type carbohydrates, the resistant starch, and the dietary fiber, as well as protein and lipids. So any of those non-digestible materials can actually be candidates, but there's 3 requirements for prebiotics. Number 1 is that it's resistant to the gastric acidity and hydrolysis by mammalian enzymes and GI absorption, so it's non-digestible. The second is that it can be fermented by the intestinal microflora. And the third is that it selectively stimulates the growth or activity of the intestinal bacteria associated with health and well-being. So any non-digestible product that goes into the gut that meets those 3 categories are going to be considered a prebiotic. All right, so something that I thought was really, really cool is the Human Microbiome Project. And for those who went to the Pediatric Symposium with NASCAN, they kind of talked a little bit about stuff that came out of this. And in the past, really the microbial species that were studied could only be studied in isolated units. They couldn't study these microbial components in their natural environment because they couldn't create the natural environment in the laboratory. So the mission of the Human Microbiome Project, which was established in 2008, is actually to make a comprehensive characterization of the human microbiome and analysis of its role in human health and disease. So they're actually kind of similar to how they did the Genome Project, where they actually started mapping the human genes. They're now mapping the gut microflora of humans. So they're examining the microbial communities in the natural environment, and they actually found that these microbes carry out metabolic reactions that are not coded in the human genome. So it kind of was hypothesized in the past that most of our metabolic reactions that happen in our body are going to be somehow coded in our genes, in our genome. So it was really interesting that these microbial components actually carry out a lot of those metabolic functions. All right, so in trying to understand prebiotics and probiotics, we need to kind of understand the human gut microbiome that actually exists. And this goes all the way back to Louis Pasteur, and it kind of started with the germ theory of disease, where he proposed that microorganisms infect humans and animals, causing disease. And a lot of that was really proven, and it helped to develop strategies like vaccines and pasteurization. So that's where we get that word pasteurization from. In 1885, he proposed an interesting idea for a study where he would like to raise an animal, either a rabbit, guinea pig, dog, chicken, or something like that from birth. And he wanted to really remove all of the natural nutrition from that animal. And he wanted to artificially derive a specific food that had no microorganisms in it. So basically a sterile feed. And his hypothesis was that life would be impossible if given that type of food that had no microorganisms in it. Eventually, Bernard Wostman developed a laboratory that could actually breed these experimental animals under germ-free conditions. And what he found is that these animals did live. So in that instance, Pasteur was really wrong because he thought that they would die. They wouldn't be able to survive. But he found that life is actually possible under germ-free conditions. However, Pasteur was really on the right track because these animals were found to have very, very high nutritional needs, and they did not develop normally. So what they found was that microbial colonization is not essential for life, but essential for the growth and development. And so that was a very interesting thing that they found, which actually relates to the WIC program in specific, and I will get to that later on. Slide. All right, so understanding our microbiome, the human GI tract houses over 10 to the 14 microbial cells, which is basically 1 with 14 zeros behind it. So that's a lot, which I think we all know. There's over 1,000 different bacterial types. But how this really relates to the WIC program, specifically for us, is that colonization really begins in the birth process. So the infant is born with a sterile GI system, and colonization doesn't actually happen until the baby is born. And how that begins is from the maternal either fecal or vaginal flora, and also the environment. So once the birthing process starts, that baby's gut is starting to colonize bacteria. The bacteria that colonize the infant's gut are going to largely be facultative anaerobic strains like Escherichia coli and Streptococci. But the subsequent colonization is determined by the feeding profile. So this is very, very important for our infants that we're encouraging them to breastfeed, because that's really where a lot of that colonization of the beneficial bacteria, the sealing of the gut so that they don't have that leaky gut, the permeable gut with the colostrum, is where that is really, really very important. So we talk to our moms a lot about, it's good for their immune system. It's good for it's good for you to lose weight. It helps prevent, breast cancer. And we talk about all those kinds of things, but I think it's good for us to understand how that really does affect the baby's GI system. And a large majority of our immune system is in our GI tract. So this is how that kind of affects that. All right, so the final phase of the microbiota acquisition occurs at weaning. So again, this is really related to the baby's diet. Once they wean from the breast or wean from the formula and they start to eat solid foods, is when that final acquisition of bacteria is going to actually occur. All right, so the complex microflora develops. These are largely non-spore-bearing anaerobes. So the Bacteroides, the Clostridium, Lactobacillus, Fusobacterium. There's various gram-positive cocci. And then lower numbers of the Enterococcus, Enterobacteriaceae, methanogens, and the dissimilatory sulfate-binding bacteria. So just a lot of different kind of bacteria that are actually in the gut. All right, so how these gut microflora, these probiotics, work in our GI system is they actually ferment the available substrates. So when we eat food, and they have these substrates in them, including starches, soluble dietary fiber, oligosaccharides, and the non-absorbable sugars and sugar alcohols, which are derived from our diet, but also some exogenous secretions as well. These bacteria actually ferment those substrates and create byproducts. So the gut flora, again, can be beneficial or pathogenic. All right, so that was a lot of scientific terms and whatnot, and I really want to get into how this really affects our health. What are the benefits for having these prebiotics and probiotics? And you can't see that on your screen, but hopefully you've got a printout, or you can actually look at it on the computer later, because I think this is very interesting. There were several diagrams. One of them was actually with the endocannabinoid system, but that kind of was going to approach a topic I didn't really want to discuss today. So I chose this diagram just to illustrate just one of the interactions that we can have between our microbiome and the rest of our body. So this is actually a bidirectional communication between the gut microbiota and the brain. Multiple pathways exist to which the gut microbiota can modulate the gut-brain axis, including the endocrine system with cortisol, the immune system with cytokines, and also the neural system with the basic and enteric nervous system pathways. And so what happens is in times of stress especially, the hypothalamus pituitary adrenal axis can actually regulate the cortisol secretions, and the cortisol actually affects the amount and numbers and types of bacteria that we have in our system. In turn, those bacteria, those probiotic bacteria, can also affect the immune system and the levels of the cytokines. And that actually can affect the messages to the brain. So both the vagus nerve and the modulation system of tryptophan can also strongly impact the influence of the gut microbiota on the brain. And then in addition, short-chain fatty acids are neuroactive bacterial metabolites. So these bacteria get in our gut and they ferment our substrates. They produce these byproducts, including the short-chain fatty acids. And those also can modulate our brain and behavior as well. So you can see when you get down to just the basics of it, we're actually having a reaction between, an interaction between our brain, our GI system, and the bacteria is really one of the intermediates that are just necessary for that to happen. All right, so looking at some of the specific public health benefits, the research has really noted potential relationships between the gut microbiota and a lot of different areas, including alleviation of GI symptoms. So we know, we've heard it before. I'm not sure, somebody's got their speaker maybe on. There's a lot of noise. Oh, thank you. All right. So we know, I think we all know that probiotics can be used in the alleviation of GI symptoms. For the other dietitians out there, I'm sure when they were in the hospitals doing their clinical rotations, if they had a patient that was on a medication that caused severe constipation or severe diarrhea, a lot of the times one of the interventions that we would do is to recommend to the doctor to give them a probiotic, and that would help alleviate some of those symptoms. Y'all have all seen the Activia commercials, some of those other commercials where they're talking about the beneficial probiotic bacteria and how that alleviates some of those symptoms. Another benefit is the immunostimulation. So our GI tract houses our immune system, a lot of our immune system, and these bacteria, work specifically in that area. Some other implications have included cancer, cardiovascular disease, some of the Crohn's disease and colitis and stuff like that, the IBDs. Neurological disorders, including autism, have had some implications in research. And then they've identified 26 species of bacteria actually linked to obesity, insulin resistance, high blood glucose, cholesterol, and blood pressure. And also bacteria are involved in vitamin synthesis, which we know as well. All right, so I'm going to highlight just a couple of specific benefits that have really come through in the research that really relate to our job in general, working with women, infants, and children. And the first one is infant colic. Colic is really hard to kind of define. There's not really a specific definition out there. You'll have a lot of doctors say, oh, the baby has colic. Or you'll have a parent say, my child is colicky, I have a colicky baby. But colic is really kind of defined by excessive crying of unknown cause. It affects 20% of infants less than 3 months of age. And this actually can be really, really hard for mothers. Anybody who's had an infant with colic can testify that this is just, it really affects your daily life, interrupts a lot of things you do. It's strongly associated with maternal depression, child abuse, early cessation of breastfeeding, and then it's also suggested that it may affect behavior and sleep problems as well. So the etiology is really unresolved. as you can see in the definition, it's just excessive crying of unknown cause. They don't really know what causes it. And there's really no treatments to date that are specific for infant colic. They've got the gas drops that you can get. Some of the drugs back in the 80s that they use have really been found to be quite dangerous for infants. So there's really no good medication or treatment that the mom can get from the doctor for colic. All right, so Gwenna gave me one study. I looked at a study on infant colic that really examined two specific species of Lactobacillus reuteri. And they studied, the study with breastfed infants found the strain very effective. However, the subsequent study with the breastfed and formula-fed infants found L. reuteri DSM to be ineffective. And I think, that's a really good area for a lot more research, because we know that breastfed babies can have less GI symptoms, and they tolerate the breast milk a lot better than they do formula. And I wouldn't be surprised if that has a lot to do with the outcome of this study. There were two additional studies with mixture of probiotic strains, was also found to be very ineffective. The reasons are unclear, and there's need for further study, because current studies are just not overcoming the limitations. It's hard to get a large sample size with these infants. There's a short period of time when you can catch an infant with colic. So, some of the limitations of these studies have really been due to the sample size. So there's another study that's been proposed in Britain that's actually going to take place. I believe it's in Britain. And this is an IPDMA, which is an individual participant data meta-analysis. And basically, in the meta-analysis, what they do is they pool a lot of other studies from random control trial studies, and they really look at the data, and what they're wanting to do is determine whether the probiotic L. reuteri DSM is effective in managing infant colic, determine whether the effects of this strain differ according to the different feeding types. So this, I think, will answer that question that was really lingering from the other study of, does the probiotic differ when you have an infant that's exclusively breastfed versus partially breastfed versus fully formula fed. They also want to look at, is there a difference when you have an infant that's on a proton pump inhibitor? So if you've got those babies that are on Zantac or that are on, any of the other anti-GERD medications, which a lot of the babies that have colic are going to be on those medications as well. They want to examine whether or not the hypoallergenic formula exposure has an effect, and then also the maternal dairy elimination diet for breastfed infants, whether that actually has an effect as well. All right, so the methods of the proposed study for the IPDMA is based on the methods recommended by the Cochrane collaboration and the PRISMA guidelines, which is not really important for us to know. It's just important to know that they do have actual guidelines that they follow. And they're only using registered random controlled trials using recognized online search databases. So what they're hoping to find in the outcomes of the study is, does the probiotic have an effect on the infant crying duration? Treatment success would be defined as at least 50% reduction in crying at 21 days post-intervention. They also want to look at, is there an outcome in sleep duration, parental report of success, and also any adverse effects that the probiotic might have on the infant. So does it cause diarrhea? Does it cause gas? And stuff like that. All right, so constipation. I know y'all have probably had a lot of parents come in your office saying that their child gets constipated, or they check the box on the paper, constipation. So I want to briefly go through what is the definition of constipation, because I think a lot of people think their child is constipated, or they think they're constipated, and they really just aren't. They have, maybe they go every other day and everything else is fine. So in general, constipation is defined as a bowel movement less than 3 times per week with symptoms of irritability, abdominal distension, cramps, decreased oral intake, and the passing of hard or dry stools. So, some breastfed babies may go once a week, but they don't have any of the other symptoms. Everything in general is fine, other than they just don't go every day. So not necessarily normal for every baby to go every single day. Delayed or difficult defecation greater than 2 weeks in duration without an organic cause, like without being caused by medication or being caused by a specific medical condition, is really considered functional constipation, also called fecal retention or fecal withholding. And there's really a decreased quality of life when this happens. People who have this issue, they don't want to eat, they don't feel good, they just, in general, are just going to feel lousy. All right, so the benefits of these probiotics with constipation, how our colon functions is really to remove the water from the stool before elimination. So if the child is not, or the person is not passing a stool frequently enough, then that stool is going to remain in the colon for long periods of time, and even more water is going to be removed. This is how it results in dry, hard stool, becoming difficult to eliminate. Withholding stool can then lead to weakened or stretched muscles. Nerve damage can actually result, decreasing the child or the infant's sensation to even need to use the bathroom. The bowel movement is further withheld, and then you can actually have pretty serious complications where soiling and incontinence can result, which is called encopresis. All right, so that being said, constipation, I think sometimes myself, I tend to downplay it, talk to the parents, oh, well, maybe the child's not really constipated. See the doctor. The doctor doesn't really talk to the parents about the constipation. They hand them some Miralax and tell them to take it every day. And so, constipation left alone, even though it seems like a minor problem, can actually turn into a really major problem for the child and the parent. And some of the causes of constipation can be muscle dysfunction. That can be due to a medical condition. It can be due to nerve, dysfunction within the muscles. Medications can cause constipation by decreasing the motility. Environmental factors can also be included. I thought it was very interesting when I was reading that some children can just retain from actually using the restroom, and it can be as simple as the way they're positioned on the toilet. So some of these environmental factors that we don't really take into consideration of, are they asking the child often enough if they need to use the bathroom? Is that playing a role? And then, of course, more importantly to us, the dietary factors, inadequate fluid intake, or even excessive fluid loss. Do they have a drooling problem? Maybe they've got a medical condition where they drool a lot, they lose a lot of liquid that way, or they're just not getting enough liquid in their diet or their foods. And then also a lack of dietary fiber, which is going to include a lot of those prebiotics that are going to help our bacterial flora. So a lot of these are going to be the things that we're going to focus on in our counseling. All right, so I have a chart here. Again, you can't see it on the screen, but I thought it was really interesting to see the different types of laxatives. I have a lot of children that come in my office on a weekly basis that are taking Miralax, or they're taking the lactulose. The doctor's giving them some kind of powder to mix in their milk or their yogurt or whatever. And so this just shows the different types of laxatives, the site where they actually work in the body, so whether they work in the colon or the large intestine, and then the brand names that actually fit under those categories. So that's something that you can just refer to later. All right, so the major benefits for constipation are going to be the prebiotics. So we talk a lot about probiotics and how that's helpful for constipation, and it is. But the prebiotics are really, really helpful. And this is where I want to really stress that this is really referring to the diet. When we talk about prebiotics and probiotics, you don't have to take a pill for this to be something that we can recommend for our parents. This is completely under our scope of practice. So when we're talking about the prebiotics, we're talking about those soluble and insoluble fibers. So soluble fiber, including the legumes, the oats, some of the fruits like plums, berries, apples, pears, some of the vegetables, including broccoli and carrots, and then some of the root vegetables as well. The insoluble fiber really being like the skins of a lot of those fruits and vegetables, the green beans, the leafy vegetables, the flaxseed, the skins of the potatoes, nuts and seeds, and also the whole grains as well. All right, so when we talk about fiber recommendations, I think we all know that most Americans don't get enough fiber, and most American children don't get enough fiber either. But it's hard to know, like, what can we recommend for these children? The first thing I would stress is that if you've got a child that's really struggling with severe constipation, let them see the dietitian. The dietitian can, work with them, if not once, but many times, to help them really tailor their diet. But the recommendations right now are going to be, for the minimum, it's going to be the age +5, and the maximum to be the age +10. And I think from the NAFSCAN symposium that we went to, I recall them saying age +4, so I don't know. There's really no specific recommendation. A typical recommendation is going to be 14 grams per 1,000 kilocalories. So if you have a 3-year-old that comes in your office, their range of fiber is going to be between 8 and 13 grams of fiber. Okay. So some things that we can counsel them is, what are those foods that are going to include those, the fiber, the insoluble and the soluble fiber, increasing the fiber slowly to prevent so many, adverse GI symptoms. If they increase the fiber too quickly, they're going to get some of the GI symptoms, the cramping and the other symptoms that are just really not pleasant. Another thing to mention is that fluid intake should be increased. So anytime a parent or person is going to increase their fiber, definitely stress to them to increase that fluid intake, or they're going to end up even more constipated. Something I found very interesting is that blenderized and mashed foods contain more fiber than the commercial baby foods. So if you've got a mom who has an infant that is just really struggling from constipation, an infant that already takes foods, maybe counseling on her on the idea of just mashing those really soft vegetables, when they're at the table and whatnot. That way they can increase the fiber. Of course, being mindful of food safety as well when they're making the baby foods. And then really being creative when counseling children with feeding difficulty. So a lot of these children that are constipated have feeding issues to begin with. And so maybe they don't have a varied diet. They don't have a diet high in fiber. They may only eat one specific kind of food. And then you can have the children that are struggling from the severe constipation who become very picky eaters because they just don't feel like eating, and they may pick and choose a few things that they really like to eat. All right, so that was just, it was a lot of information, but a few things that really impact our counseling here in WIC. And right now what I want to do is open up the floor because I really want to know what are some ways that we could use this information with counseling parents. We see women, infants, and children. We see a select population. But what are some ways that we can use that prebiotic and probiotic information when counseling patients? Region C.
Hey, Lindsay, it's Carly. I don't know what C is equal to anymore.
I'm sorry, Region 3. I'm still back in the day. I'm sorry.
I know. You're fine. I'm like, I don't know. But first of all, I wanted to say excellent training. I love this. I'm doing a happy dance over here in the morning.
Thank you, Carly.
And then I've actually counseled a lot of patients on this, especially for those kids that have constipation, because most of the time what you find is they're not, their diet isn't varied, like you said. They're not eating as many fruits and vegetables. They don't drink water. They don't have any form of prebiotic, probiotic going on, for the most part, they may live on chicken nuggets and macaroni and cheese. Right. So this is something that I mentioned for some of the special needs children, especially. I'll mention this if they do have already, GI issues or compromised systems. Just mentioning, have they talked to the GI doctor about intake of probiotics, depending on if they can eat orally or not. And a lot of the GI doctors I've been impressed with, because they will, talk with them about it most of the time before they even get in, the office with me. So I think that's great. And just giving them alternatives, like you said, in the food versus having to take something like Culturelle, which costs $30 a box.
Right.
So, because a lot of the GI doctors will say, well, go buy a box of Culturelle or go buy a box of Lactinex. And it's really expensive for people, that we see. But if they can get some Greek yogurt, if the child can eat by mouth, or even like kefir, which is the lactobacillus yogurt, liquid yogurt to drink, it's cheaper and it's more beneficial than taking it from the pill. So that's kind of how I've been using it, counseling my patients.
Absolutely. I think those are all really great points. Something that those of us that went to the NASCAN symposium, when we got to talk to some of the professionals there and some of the reps and whatnot, what I found was it impressed me a lot, and I found it very interesting, is that they really talked a lot about fiber and how important fiber really is for children. I don't think we really, and especially a lot of health professionals, I don't think we talk about that enough, of getting the fiber in the child's diet. A lot of the things that the children eat are very low fiber foods. The crackers and the cookies, the cereals, the chips and the pretzels and some of those things. So I think those are all really good points, and especially, Carly, what you mentioned about the Culturelle and the other probiotics is that a lot of the probiotics that are really marketed towards children, now this is according to the Culturelle rep at the place, but I actually agree with what she was saying, is that a lot of them are sold in the form of gummies. And the gummy form, in order to make it into a gummy consistency, you have to heat it. And so a lot of the bacteria can be lost in that heating process. So they're paying, and Carly wasn't exaggerating, they're paying $20, $30 for a month's worth maybe of this product. That, how effective is it? I mean, how long was it sitting on the shelf? Are the cells still viable? Are there enough viable cells in there to begin with? Was it a heated product where all the viable cells were lost before it even got to the shelf? So these are a lot of good reasons, including our scope of practice. These are a lot of good reasons why it is really, really important for us to help these parents determine how they can change the diet of their child to really help alleviate these symptoms. Does anybody else have any thoughts?
Hey, Lindsay. Good morning. I just wanted to say two things. First of all, this is just a great reason why we need to encourage our mothers to breastfeed in the beginning, and then the long term too, because you're setting up your child's gut to prevent some of these problems. I mean, these bacteria. I mean, it's not just in the beginning, but at last, it just sets up a healthy gut. And the other thing is, I wanted to thank you for the recommendations about the fiber for children, because I was doing Shopping Matters last week, talking about fiber, and I realized I had no idea how much children needed. So, thank you.
You're welcome. Yeah, that's kind of a tricky, there's a lot of different information out there. You could Google how much fiber does my 4-year-old need, and you'll get 40 different answers. I mean, there's a lot of different recommendations, and what I want to say for our nutritionists especially is that, give them that range of what is normal, the minimum, the maximum, and tell the mom, start at the minimum and start slowly. And if you get any adverse effects from it, the child's getting a lot of gas or a lot of, if the child's having diarrhea, then back it down a little bit. So, not a specific dietary prescription, but just a rough estimate of what is normal. Because we get way fewer grams of fiber in our diet, even as adults, than we really should. So thank you, Carol. Anyone else have any thoughts about how they could use some of this information when counseling their patients?
Lindsay, this is Erica from Upson.
Hey, Erica.
I just wanted to say awesome presentation. It was very informative. And I would definitely use this for my prenatals. A lot of times they don't want to take extra pills or extra anything when it comes to incorporating things into their diet. And a lot of them come in constipated. They don't drink a lot of water, and they don't get a lot of their prebiotics and things in. So I would definitely use this information for my prenatals to give them some ideas of things that they can eat and not just always taking pills and drinking probiotics.
Absolutely. That's a good point, Erica. A lot of the prenatals do come in constipated. That's partially due to the hormones. And then they're taking a large amount of iron in their prenatal vitamin. They might be taking some extra iron on top of that. So we all see a lot of prenatals come in that complain of constipation, and I've even talked to prenatals that will stop taking their prenatal vitamin and their iron because they're like, I'm so constipated, I can't tolerate it, which is not good for them. So I think that that's a really good area to use a lot of this information. There was also some literature that I saw out there that I didn't include, but was kind of interesting about probiotic use in prenatals and how their children have a better immune system when they're born. So I thought that was really interesting information as well. So I think definitely could benefit all of the patients that come in our office. All right. Any last comments before we kind of wrap up?
Yeah, Lindsay. I'm also doing my happy dance over here like Carly when I saw the topic today. Great job, great presentation. But I've always been preaching high fiber, because you do see a lot of constipation here in the clinics. And a lot of moms are scared off by some of the high fiber foods. They're like, "Ooh, I don't want to have gas all day." And you let them know to introduce it slowly, and also increasing their fluid intake. So I appreciate you reiterating that for us. And also, I've real life scenario. I've been working with my family on a high protein, high fiber diet. And I've seen a lot. We also can use it to talk about weight loss too as well, because I've seen a dramatic increase or actually decrease in the body fat of my family. So we're getting healthier, more muscle mass, and so I just want to reiterate what you were saying, and great job.
Thank you, David. I had to exclude a lot of information. This is a very large topic. But speaking of obesity, the probiotics and the prebiotics actually have an interaction between the hormones and the brain. That was that endocannabinoid system that I didn't really want to include because I didn't want to get too far off topic on some current issues. But they're really, in the literature, they really are suggesting that there is a link between the gut flora, the type of gut flora, along with the amount of gut flora, and obesity. And they're finding that in obese people, they have a completely different gut microflora than healthy weight individuals. So, including a lot of these foods to really encourage that healthy gut microflora, I think can even help with along with the fiber in the weight maintenance for a lot of these patients. All right, so we'll go ahead and move on to the last couple of slides. Just some of the implications in WIC. Again, just want to reiterate our scope of practice. As nutritionists, we're not our scope of practice is not to prescribe a diet. We want to encourage a general healthy diet, which I think these prebiotics and probiotics fit in perfectly. So encouraging a diet rich in food sources of prebiotics and probiotics, first and foremost. You can always encourage the mom to say, hey, talk to the doctor and see if if this is not working for you, is there a probiotic that's got a higher CFU count, a colony forming unit count, that will really be beneficial for them, and then let the doctor really prescribe a probiotic or something for them if they feel it's necessary. But like y'all all had mentioned, we can use this in counseling obese women and children. We can counsel, obviously, women and children with constipation. And then, the research is kind of unclear on families dealing with colic, but I don't think that this would hurt to really encourage them and give them another good reason to continue breastfeeding the baby when they might be ready to give up. My baby's so fussy, and just let them know, hey, your breast milk has got all of those beneficial bacteria and beneficial components that are really going to help your baby. The formula does not have. So just really encouraging them to continue the breastfeeding as well. All right, so the last slide, I just have a couple of quotations on good to great. And the first one is from, well, they're both from James C. Collins, which actually I think wrote the book. But the first one is, it's far better to dare mighty things, to win glorious triumphs, even though checkered by failure, than to take rank with those poor spirits who neither enjoy much nor suffer much, because they live in the gray twilight that knows not victory nor defeat. And then last but not least, great vision without great people is irrelevant. So, I want us to all in our day, we can get caught up in the routine of WIC, and we get busy sometimes, and some of the clients are difficult to handle sometimes, and we want to just get that next cert done because we've got a bunch on the wall. And so I want us to all be mindful of really daring to put ourselves over that line of mediocrity. Even though we may fail sometimes, it may fail miserably, and we'll be like, man, that just didn't go the way I thought it was going to go. And really encouraging us to to use those strong for life concepts, and the vena-friendly, letting the patient really lead the conversation. It won't always go the way you want it to, but the more you do it, those failures will become less and less. It'll become like second nature, and you'll get really a lot more meaningful conversation with the clients. And then we can have a great plan here in WIC all day long, but if we don't have great people, it doesn't matter. So I just want to say thank you for all of y'all. Y'all are all great people. You wouldn't be here if you weren't, and just encourage y'all to just continue with greatness, okay? And then I've got the references on the last slide, and that's pretty much it. If y'all have any further questions, feel free to ask. If not, have a wonderful Tuesday.
Great job. Thank you, Lindsay.
Thanks, Lindsay.
Thank you, David.
Thank you, Lindsay.
Good job, Lindsay.
Thank you.
Lindsay, you rocked my socks off. Have a great day.
Thanks, Carly.